Hi, this is Tracy Meyer with ADHD Live Medical Associates, ADHD specialist and nurse practitioner. And I have Mariah Prince, Dr. Mariah Prince, with me, who is a hormonal specialist, which goes very closely with ADHD. So I'm excited to talk to you.
I'm excited to talk to you too today, Tracy. Thanks so much for having me.
Yeah, absolutely. So your career has been impressive. You got your degrees, your master's and doctorate degree from Duke. That's pretty awesome. Tell me a little bit about your background.
So, I'm Dr. Mariah Prince Allen. As Tracy said, I'm a nurse practitioner, and my career has definitely gone so far beyond, I think, being a nurse practitioner. It's led me to opening my own practice called Telehealth for Her, which I help high achieving women balance their hormones, fix their gut, and have, metabolic masteries, like what we like to call it. So they can just feel good and continue to be the powerhouse women that they love to be. And I think from my just general love of teaching women, that has also led me into becoming a keynote speaker and a recent TEDx speaker, and have also done a little bit of things in like corporate as well, just kind of helping businesses understand the importance of women's hormone health in the workforce. So that is kind of the trajectory that my career has taken off since becoming a nurse practitioner now 9 years ago.
Is amazing. What did you start off in
So I actually
with your
started
career?
off as a neuro ICU nurse and step down nurse. And then when I became a nurse practitioner, I worked in heme malignancies, or like the blood cancer world, taking care of patients with leukemias and lymphomas. I had a cousin who had leukemia in her early 20s. So that's kind of where that passion came from. But I always loved women's health. So I'm glad that my career has brought me back home.
Yeah, yeah, no, that's awesome. That's awesome. And I bet all that experience really helps you, be able to examine the full person, right? So it's something I think a lot of specialties are missing is focusing. I mean, you have to focus on your specialty. That's what you do, but also trying to understand all the complexities that are working together as well. So, Mariah, talking about women and hormonal health and ADHD and how it intertwines so closely. There's not a whole lot of research on ADHD or hormonal health. And so, how did you come about this and get trained in this?
Yeah. So I always loved women's health, but when I was in school, I'm a family nurse practitioner by trade. So ideally, I was supposed to learn how to take care of people from womb to tomb, is what they tell you. But I started to realize that there was women in their 40s and 50s who was really struggling, and no one had any, recommendations for how we're going to treat these women or even knew what to do with them. We said, okay, maybe they're going through menopause, and that's kind of what we called it. And we said, just kind of suffer through it. Eventually, you'll get over it. And I think too, prior to like the Women's Health Initiative study, we were putting
Huge.
women on HRT. And then that study came in 2002, and we said, absolutely not. It's dangerous. So we made every woman since then suffer through menopause. And I think we're starting to slowly but surely kind of come around the corner and realize that HRT is great for women. But it was in that realm of seeing women suffering that I was like, something has to be done. Like this can't just be an end all be all to the women who are really holding our community together. Like these are the women who are taking care of the future generation and caring for the aging population. So we can't just, dismiss them. And they're women who are
Right.
young.
Right,
Yeah.
absolutely. And just, for people who don't know that study really well and don't know what we're talking about, that was a study on hormonal replacement for women in menopause. And, it basically was a poorly done study. And when it put out its reports, it said that women had an increased risk for breast cancer and that we should not give, hormonal replacement anymore.
So I think some of the biggest flaws in that study was one, it was giving women much higher doses of HRT than we do today. It was also giving HRT to women who are much older than the women who we treat today. So a lot of the women were in their 60s, 70s, and even some of them in their so of course we were probably causing these women to have, heart disease and blood clots. But it's also hard to determine, like, did the HRT do that? Or did they just get it because they're in their 70s and 80s? So they just happen to develop heart disease. It was hard to really correlate the two. But I think that was the pivotal study because when we looked back at it and, we're starting to dissect that study, we're like, well, women who go through menopause are in their mid 30s to clearly they're not even in their 60s, 70s, and 80s. So, Like, let's have a different conversation. And then let's look at, the doses and what we were giving these women in this study. And we realized that women don't even need that much of a higher dose of HRT to actually control their symptoms and things like that. So, I think one of the things that came out of that study and some more recent data is that the FDA recently like, estradiol patches. And this is how low the patch dose is 0 to 5. Like, it is a very small dose of estradiol, but it's enough to start to protect women's, from the hot flashes. But they also have seen that, that low dose also helps to protect heart, bones, brain, and things like that too. Yeah. So we learned a lot from.
Yeah, I love that. I love that. We are still suffering the impacts, though,
Hmm.
on the misconceptions that that study unfortunately put out. And there's a lot of practitioners who still aren't comfortable prescribing estrogen, which,
Yep.
that is, for me being a 44-year-old, woman, and hey, I'm just, it's just right around the corner for me. I need that. And, for ADHD, and that's the interesting part, right? Because estrogen and dopamine are kind of modulators of each other.
Mm.
So they're very highly affected by each other throughout the lifespan from puberty to postmenopause.
Yeah.
And that's why I see a lot of women whose ADHD symptoms go way up when their estrogen levels fall during every single month right before their periods. And then, all of a sudden their ADHD medicines are working better again because their estrogen levels go up. And this little game that continues to play until perimenopause. And so, kind of define, what does that mean? What age does it start? How do we know that we're even in it?
Yeah. So I think one of the things is to know is that the average woman goes through full blown menopause around 52. So menopause is defined as not having a menstrual cycle for 12 consecutive months without surgeries or birth controls or things of that nature. But what we don't always realize is that the perimenopause transition. So I always tell people menopause is the moment. It's literally the day on your calendar when you have no periods for 12 consecutive months. But that transition point to get there is pause. And that can last for a decade for some women. So imagine if you're supposed to go through menopause at the age of 52, that means about 42. You're starting to have some of these perimenopausal symptoms. And now, probably from a lot of different things, like, a lot of endocrine disruptors and things of that nature. But we're seeing that women are actually starting to go through perimenopause in their mid 30s. And they're not having the same hot flash type of a symptoms, but they're having more of the fatigue, more of the weight gain, more of the brain fog, and then eventually the hot flashes start to come. So it's like those minor changes, as you were just saying, for your women who go into ADHD and they're going through their menstrual cycle, how they get these minor changes of their symptoms, kind of the same thing for those younger women until the hormones really start to have a more of a drastic change and shift.
Yeah. And so, how do you measure, hormones? How do you?
And so I think it's a lot of different. So there are multiple ways you can measure a woman's hormones. So there are blood tests, there's saliva tests, there's urine tests. I usually just start off with blood tests because it's just a little bit more feasible for women. It's not as expensive as the saliva and the urine test. I will do those things if I'm not getting clear answers and I need a more deeper dive. But it really just starts off on, testing the hormone levels. But one of the things that I like to tell women too is that when I check your hormone levels, whether that was, through whatever method that was, it's giving me one snapshot. So I really need the full picture of their symptoms and their story, because that is really where you're going to get all of your answers from, not just checking their labs. Like, their labs will help you to kind of put the puzzle together, but it's just one small piece. You actually got to sit down and listen to the females, and you'll get the rest of your story and be able to kind of decipher what's going on with them.
Yeah, it's like a lot in medicine. I mean, people think it's very black and white, but it is an art.
It
And
is.
you learn how to play that game and to look for those clues and just to paint that picture of what's going on. To be very good at your interview skills, you have to listen, and you cannot rely on one single measure of
No.
anything. Right. So something that frustrates me, people just don't understand.
Yes, they
This
don't.
is definitely an art. So, and like you said, it's just one snapshot in time. The things that are affecting that blood test, can that be affected if, stress levels, cortisol levels, can it be affected by recent illness? What kind of things make that less accurate?
Yeah, so I would say in the world of checking for hormones specifically. So if women are on oral birth control pills, I don't even waste my time checking their hormone levels because it is so not going to be reliable. So for most of my clients, if they come and they're on some form of oral contraception, I will have them come off of it and find another contraceptive method. And typically have them off of their oral contraceptions for at least 3 months because I need their body to kind of re regulate so I can understand really what's going on. But I think it's also so important too that when we're thinking about menopause and perimenopause, you have to really check more than just their female sex hormones because there's so many other things in the body that can mimic perimenopause, right? So if a woman's coming and she's saying she's having all this weight gain, okay, great. She could be perimenopausal or she could have insulin resistance and like gut problems, right? Or she could have
Right.
thyroid problems. So it's also too not just being like so narrow minded that we could miss other things that are mimicking perimenopause and menopausal symptoms, right?
Yeah, I mean, same with the ADHD. I can't do a lab test and
Right.
say, "Here you go, here it is." I mean, ferritin levels, iron levels, those can affect brain fog, right? Or like you said, the thyroid hormone
Mhm.
levels can really affect cognition. Vitamin D levels can affect it. Health, the brain gut barrier.
Oh,
Gosh,
yes.
that's exciting in medicine right now to kind of see the relation of that. So there's been a lot of research in that, and that's super, super interesting. Hats off to people like you. I've looked at kind of gut health and testing and everything, and
It's
it's
so
like,
fun.
wow, I'll stick to my ADHD and refer out. It is another art form of medicine and something that I'm sure you've done a ton of education on. But yeah, it's a real thing. It's a
Right.
real thing.
And I think too, it's important too because my clients are always like, well, when am I going to actually start my HRD? And
Yeah,
I always am telling them, we're building your house that you're going to live in for the next 2 to 3 decades of your life, right? So if
I
I
love
built your
that.
house like overnight, do you think that house would really last you into your 60s, 70s, and 80s? Probably not. So I'm always like, let's fix the foundational things, right? So just how you just said, vitamin D, vitamin B12. I cannot tell you how many women show up to me and they are deficient in just those basic vitamins and nutrients. So I'm like, okay, let's fix that first, right? And then it's like if I notice that, they're having some gut things, so they have high inflammatory marks, I'm like, let's fix all of that first. Because if we don't fix that first and I put you on HRT, you may feel better for a little bit, but that inflammation is still there. That vitamin D deficiency is still there. And those also have symptoms. So it's like you may not always feel the greatest if you just, here's your prescription out the door. So you really got to take time to really figure out what are the foundational pieces that is missing in this woman's health so that we can actually be able to set her up for long term. And those are just things that you can't fix in a 10, 15 minute primary care doctor's appointment, unfortunately, because they just don't have the
No,
time.
there's so much to cover. There's
Yeah.
so much to discover
Mm.
and learn. So, and diet, it's so interesting, right? I have a blog because, again, estrogen's so interesting to me because it has to be. It affects my ADHDers and my medication management. But, there's estrogen positive diets out there, right? I mean, there's just what we eat affects our estrogen. So yeah, you will never have a conversation with your PCP likely to kind of explain that or learn more about it. It's not because they don't want to. They don't have time.
Yeah, they don't have time.
They don't have time. They have these, windows of time. They're trying to serve a lot of people. Physicians, they don't get a lot of education on this unless they choose to go out and learn more about it. And so my history is the same. I have passion for this. I saw a need for it. It's very close to my heart. My family, a lot of us have ADHD, and I just want to make the world a little easier for others
Yeah.
and to help other parents too that have kiddos with ADHD to understand them more. But I had to go and do all this education on my own. And I wish that the medical field really provided more information from the get go,
Yeah.
and not just leave it up to the providers to go and continue their education and knowledge on this because they probably won't. I mean, medicine's a big ocean. unless I love ADHD or
Yeah.
hormones,
They're
they're not
not
gonna
gonna
do
do
it.
it. And I think too, to your point, it's like when you're not exposed to those things in school, you don't know really what your passion is until you get into the field. But I think also too, the way that we treat people and the way that we learn in school, it's all very reactive medicine. So I learned how to manage blood sugars and how to treat diabetes and how to diagnose heart failure and all of these things, right? But what if I would have learned women's hormone health? Because in 2000 and in 2020, the American Heart Association deemed menopause as one of the biggest risk factors for cardiovascular disease in women. But what's the number one killer of women? Cardiovascular disease. So it's like maybe we should start at the root causes things and we won't have so many preventative medicine things, right? And if we really figure out, how our hormones and our brains, because they're so important, and how they really function, I think we will see a lot more healthier Americans.
Yeah,
Yeah.
yeah. I mean, ain't that the truth? I mean, preventative health it's everything. It's everything. So we talked a little bit about hormones testing. Okay, so you get the test back. What happens next? What is kind of your process? You and your patients. What does that look like?
Yeah. So in our practice, all of our patients start off with a consultation that includes a pretty comprehensive lab panel. And then I meet with them again and we kind of go through what we call their discover process. So that's really me taking time with this client for sometimes it's over an hour because I really want to get to know every detail of their lives because all of that is going to impact her treatment plan, right? So if I tell my client, for example, like I know that you have high inflammatory markers, I really want you to focus on eating some more protein and reducing your stress, right? But if I don't know that she is, a single mom with, kids going off to high school, if I don't know that, then how can I really build her an individualized plan? So we start from there, and then we kind of break each of their plans into what we call tiers. So we're focusing one on just foundational support. Where are the cracks in the foundation? How can we impact those? And then it's like, okay, great. Let's also work on the gut. Like there's a gut hormone connection. There's a gut brain connection. So let's focus on that. And then once we have gotten a really smooth foundation and we have fixed all of the things, because even women will say like, I don't have gut health problems. I'm like, yeah, you may not have the nausea, the bloating, but if you have hormone imbalance, you have gut health problems. So it's helping them to understand that. And then we start the HRT or whatever plan we come up with. And it's always centered on what that woman's goals are. And it's always not just her goals for today, but it's her goals for what does she want to be doing when she's 70, right? So I have some women, they're like, yeah, I'm still married and I want to continue to engage in intercourse with my husband. So that's important for them. So I need to make sure that the things that we're doing now continues on with their sexual health and meet their sexual health goals, right? So it's always that process is always so different based on the woman who's in front of me and what their long-term goals are, and how I can help to support them while also being able to support their health.
Yeah. No, I love that. I love that. I love it how you're so thorough and how, you're a big picture, look at every system kind of practitioner because it's just huge. It's just huge. And you just can't get, enough information from, a very short interview with somebody. I know I've had plenty of patients say, this is the most thorough evaluation I've ever had. I've never been asked so many questions. And I'm like, but I need to know. I need to know if you have sleep apnea. I need to know if
Exactly.
you have perimenopausal symptoms or in menopause. I need to, rule out risk factors of, bipolar, OCD,
Hmm.
if these conditions coexist. I need to rule out what your sleep, like if your sleep is affecting this, which ding
So
ding. I
important.
mean, oh my gosh. I mean, nobody sleeps in America.
No, no one sleeps. And then we're spend so much time on our phones. So I'm like, you can't tell me that you're brain fogged and you spend all day in front of your computer or on your phone. Like, yeah, I understand your brain is fogged because I would be fogged too. You're making your brain work all day, and
Yeah.
you're not cutting off your blue lights until midnight. And then you want to be back up at like your hormones have you up at 4 a.m. So you've gotten 4 hours of sleep. So it's really just important of really teaching women also like those lifestyle things, like you just said. Sleep is so important. Yeah.
Yeah, it's huge. It's huge. If you're not getting enough sleep, cognitive impairment, I mean, you can compare it to somebody who is intoxicated with alcohol. I mean, they've done studies on it. It's the real deal.
Hmm.
So, sleep is huge for not just brain health, but your immune system as well. So, yeah, I mean, it sounds like you get deep, I get deep too. And I find that women, when they come to me, they are really interested in doing all the
Hmm.
things. But with ADHD, it can be really hard motivation, task initiation,
Yeah.
knowing what to do. Your working memory can be poor, all the things. So they just need direction. Well, let's kind of get into that whole ADHD, perimenopause, menopause.
Let's do it.
I can tell you one of the things that frustrate me is that um, I've had plenty of ADHDers come to me, and optimal treatment, I believe, is both, if you're a candidate, hormonal replacement
Hmm.
therapy with your stimulant.
Yes.
I think that is very, very important. I send my patients off to their OB-GYN because they say, hey, there's hormonal stuff going on here too. Your stimulant can only do so much. And we really need to, be able to treat both for, you to have optimal treatment. And they come back and nothing's been done. No estrogen, no tests, just kind of, well, yep, you might be in perimenopause. Yeah. And when I say this, there are plenty of OB-GYNs
Do
out
it.
there who are comfortable, who have had education, feel safe to give hormonal therapy at this point, but there's still plenty of them who are not. So, what does that look like following your patients? How often that you need to see them?
So following my patients require kind of like on which track they're in. So we have 4 tracks in our program, in our overall practice. So for my clients, initially, when I am starting them off on HRT specifically, I am doing like a 6 week phone call with them or just a check in, a voice note. And I tell them too, if you need me before that 6 weeks, then feel free to reach out to us. They have every modality to reach our practice. And I think that's also one of the luxuries of having a boutique practice is because we really get to love on our clients. So typically it's about 6 weeks at that point. And I kind of just want to see how you're doing. Have you noticed any improvement in your sleep? And I'll tell them too, like, although I may put you on progesterone today, I'm not expecting you to sleep, like a baby tonight,
Mhm.
because there is truly a marathon. This is not a sprint. This is not going to be quick fixes. We really have to re regulate your whole system. So, typically, about that 6 week mark, I'm kind of saying, okay, great. How are you feeling? Have you noticed a decrease in your hot flashes? Do you feel like you can think more clearly? Are you sleeping better at night? And they may say, like, yeah, I am noticing some improvements in this area or this one. And at that moment, I can even consider, like, if they haven't noticed any differences at all, I can consider also bumping up their doses. Although I love HRT, I'm also a very conservative HRT prescriber. So I'm not going to put my clients on the highest doses at the beginning. We start low, we go slow, we increase their doses. And then typically after that, I'm following up with them again in another 6 weeks. And at that point, I usually am repeating their lab work, not from a perspective of just, trying to chase the labs, but I want to make sure that as we are starting HRT that we continue to keep a balance, that we're not tipping any other way, especially from the progesterone estrogen perspective. And then kind of after that, it is usually about every 3 months or so until they really get stabilized, unless we're making any dose adjustment changes. And then they kind of come back to those every 6 weeks if we're making any changes. And then typically for me and like my team, if we made any changes to anything, someone is usually following up with them in about a week just to be like, hey, how you're doing with the dose change, just kind of checking in on you. Make sure they're not having like, because women like to suffer in silence. Let's just be honest. So we want to make sure that they're not suffering in silence somewhere. So we usually always will send them like a weekly voice note or just something to let them know that we're thinking about them too.
Yeah, no, I love that. What are some signs and symptoms that they might have too much estrogen or the dose is too high? What do you see in your practice with your patients with that?
Yeah. So sometimes women can experience like really bad headaches if they're on like, too much progesterone that maybe their body can't tolerate. They can have really bad breast tenderness. Some women can have, floaters in their vision from high estrogen levels. They just don't feel good. I think that is the thing too, right? So it's like if you have this woman had low estrogen and now you have given her so much estrogen that she's on the other side. She also doesn't feel good being too high either. It's
Yeah.
also just making sure that we really do find that balance. I try to teach my clients to be very in tune with their bodies, and I give them like symptom trackers, and I'm like, I know this gonna do not make this feel like this is something else on your to-do list. This is literally your daily check-in with yourself. Because also too, it's nice to know patterns, right? So if you can figure out, especially for women who may not can qualify and they have to be on non-hormonal things, I really am a stickler about them on keeping a track of their patterns of symptoms, because they may realize that when they drink their glass of wine at night, their hot flashes the next day are so much worse, right? Or if they eat so much sugar, they may notice that they have more intense hot flashes. So when they can be that in tune, then they can know what their triggers are. Not so that they can't drink their wine, they just may know that they may suffer from it the next day with more hot.
Yeah, just to really understand everything that is affecting,
Yeah.
their health is that's awesome. That's awesome. I do the same in my practice. I have a symptom tracker following medication, and because it's really hard. Are you better or are you not? Like
Like they're like, I don't
that's
know.
yeah, I mean, it's like I would have a hard time, answering those questions. I'm very educated.
Yeah.
So having the verbiage to use, oh yeah, the headaches, that could be related to that,
Hmm.
well, that's interesting. So yeah, definitely helping give clients the verbiage that these things are connected is,
Yeah.
something that's really, really important.
And just medicine in general, we're so used to having a doctor for this, a doctor for that, a doctor for this, a doctor for that. And sometimes these doctors aren't talking to each other. So it's also getting the women to understand that you ultimately is the key player in all of your potential team players. So if you know what really is happening on in your body, then if you, let's say for instance, you happen to have a heart doctor, like you can talk to them and say, okay, great, like this is what's going on. Or I've noticed that I have less heart palpitations because I was started on estrogen replacement therapy. Right. And so it's all of those different key points. So I'm always just trying to also just educate and empower women, because I'm like, ultimately, like I can try to get to know you as best as I can, but I will never know you as much as you know yourself. So, and I'm always just like trying to empower them about that, because I think it's just, we get so used to just listening to what people tell us to do and just doing what we're told. And I think for a lot of women, they have to really be empowered to say like, no, what do you think? And so I'm like giving them time. What do you think about this? And like, here are your options, and which one sounds best for your lifestyle? And they look at me like, well, I thought you were just going to tell me what to do. No, I'm not going to tell you what to do. We're a partnership in this. I'm just your
Yeah.
co-pilot. I want
Yeah.
you to tell me what your thoughts are. Does this
Yeah.
formulation work for you or not? Oh, and if it doesn't, it's okay. You don't hurt my feelings. We just go back to the drawing board. We figure something else out. What will work for you.
Yeah. I think that a lot of people don't understand, the individualness of all these treatments, right?
Yes.
I mean, they're like, just tell me what you tell all your clients that'll work. And it's no, I mean, we're all different. How we react to medicines are very different.
Hmm.
Someday I really believe that we're all going to get genetic testing, and medications are no longer going to be based as if you're this weight or you're this age, then you start at this dose, and then your maximum dose can be this dose. I don't That's not going to exist in
Yeah.
20 years. It's going to be, oh, your genes say this is the dose you should start on. So right now people like you and me are just like, i I don't know how you're going to react. That's why we have to work together. Go
Hmm.
slow, go low, go slow. Women, we suffer in so many different ways. I'm 44 and didn't get diagnosed till later in life. Back in the 1990s, women were just barely being recognized to even having this disorder. And so we've come a long, long ways, but there's a lot of women my age and just in general, we're underdiagnosed, but especially in my generation, there's so many women out there who haven't been diagnosed
Yeah.
because when they were younger, that wasn't a thing. It was a boy disease. At first, you grew out of it at 18, and
Yeah.
then it was like, oh, it can go into adulthood, but only for guys. And then it was like, women do have this. So there's a lot of women who are walking around masking. You said that a lot of women, just kind of cover things up, try to look like everything's perfect. I mean, we're people pleasers, right?
Yes.
We don't want to complain. And if there's something wrong, it must be our fault. And so we're just going to internalize it and deal with it ourselves. So they've showed up in my office and they're, 30s to 40s, and they have struggled, but been able to barely compensate
Mhm.
all this time. And they've had some harder times, maybe during their pregnancy, postpartum, maybe these times of the month, right? Where your estrogen levels dip. They have a hard time, don't know why. And then they're hitting this perimenopause. And so, the very little research that we have, which is not good, and most of this is anecdotal from specialists. They have symptoms that are worse than the more neurotypical brains. So, have you seen this? What is your experience with that?
Yeah. So I would say in my practice, we have a few ladies who have ADHD, all was like adult onset diagnosed ADHD too. But what I have noticed is for these women with the changes in their hormones, especially during the perimenopause change. So one thing that people think is that when we go through perimenopause, it's like this drastic drop of our hormones and then we have none and then we go through menopause. But that's actually not the case. Your hormones are kind of bouncing around like a basketball. So for someone who already have concentration and focus problems, those drastic shifts of their hormones during the perimenopause change is so profound for them because the average woman who doesn't have ADHD is having brain fog and inability to concentrate. And if that's already your baseline, and then I'm going to force your brain to keep doing this hormonal shifts, they struggle so bad. And I try to also to say, okay, who is actually prescribing your ADHD medications? Because sometimes they'll say, well, my doctor increased my dose, but that didn't seem to help. So then they want to see if it's their hormones, right? So then I'm like, okay, great. Well, let's check your hormones. And if I see some hormone imbalance issues, then I'm like, okay, great. How about we start a little bit of HRT to really try to balance your hormones out a little bit and see if that may help. One of my clients recently, she was just diagnosed with ADHD probably earlier this year, and then she started to have some perimenopausal symptoms. And her doctor had to increase her ADHD medicine twice, and she was still having really bad time focusing.
Yeah.
So she wanted to know, was it her hormones? And she had a very low progesterone level, very high estrogen levels. So she really didn't even need estrogen replacement therapy. She needed progesterone therapy. She needed her calming hormone back, right? And then we did that for her. She was like, I'm starting to feel, kind of like my baseline. And then she said, maybe I should talk to my ADHD doctor to see like, did I need that increase of a dose? And I'm like, how about we just do this? We're changing it one thing at a time.
Yeah,
We're gonna,
right,
because we
right. We
won't
don't know
know
what
what
works
works
and what
if we
didn't
mess with
if you
them
do too
both.
many
Yeah.
things.
So I've been in contact with her ADHD specialist and I say, okay, I'm putting her on progesterone. That's her new change. Let's give her a few weeks or even a full 3 months to kind of see where she settles out at. And then if she's still having some trouble, I can have the ability to go up on her progesterone because I'm starting her on a low dose anyway. So let's hold tight on her ADHD medication at this dose now and let's try this first before we keep cranking up her stimulant drug or putting her on a different one and saying that that one didn't work. It could just be that she just needed some underlying physiological hormone balance things. So it's also working in collaboration is always better too.
And I think that people just don't think about those things, right? Okay, your ADHD symptoms are worse. Let's increase your dose.
You're
Let's
right.
increase your dose. Well, if ADHD medicine is working on dopamine, but you have to have estrogen for there to be enough dopamine, what are we doing?
Right.
It's like, yes, I mean, these play together. We need to make sure that they're both healthy, or, one doesn't do well without the other. And that is the challenge for us. That is in the field. I hope research and, it keeps getting better and better
Me too.
because it's a huge challenge. It's a huge
Yeah.
challenge. And what about those women who may have higher risk factors for hormonal replacement? What are those risk factors and what do they do?
So for a lot of women, I have a little bit more flexible guidelines. I'll say that. So the traditional guidelines will say, it's best to start HRT if a woman is, before they turn 60 or within that decade of menopause. My strong, strict contraindications is I will not prescribe HRT to a woman who has had breast cancer, not their mom, not their sister, but them. Or if they had any form of cancer, or if they've had a known blood clot in the recent years. Will I
Now,
Yeah, so
can I elaborate on that?
yeah, so
This is me nerding out a little bit. So if the blood clot has a clear cause, like surgery or a different type of cancer? Does that change, your decision making?
So it depends on what other type of cancer it was. So if it was like an ovarian cancer, endometrial cancers, still worries me a little bit. Also too, like, was it, estrogen positive, like all the genetic markers of their
Hmm.
cancer too, because all those things are hormonal based. But also too, for me, I will, I want to know if I'm going to go to bat for this woman with her oncologist, let's just say. I need to know how bad her symptoms really are. So if she is having, terrible hot flashes, she cannot get out of the bed, she's so fatigued, and she's still within, like, let's just say that 5-year window of her prior cancer diagnosis, then I'll have a conversation with her oncologist, say, okay, great. What if we did this very small dose to see if we can get her out of the bed? Because ultimately it's
Yeah.
nice that we cured her cancer, but if she can't function from a hormone imbalance, we didn't do her very much service. And especially for those women who have had, the ovarian cancer, the endometrial cancers, and their reason they had a total hysterectomy, they don't have their ovaries anymore. We seem to forget that we put those women in surgical menopause. So we put them in menopause in their 30s or their early. And what does that mean for this woman long term? Because as I said earlier, I'm trying to build her house for her 60s, 70s, and 80s. So I like to have a conversation with them. So active cancer, I would tell you absolutely no. If you had a blood clot, I want to know why. So if that was a genetic component, are you still on your blood thinner medications? But the blood clots for me, if it was like something that was induced, then I'm, instead of putting them on an estradiol pill, because that's going to get metabolized by the liver and increase the risk of having clots when they already had known clots, I may do something topically. Because it'll be a little bit less absorbed. It's not so much a direct hit to the liver, which ultimately is what metabolizes our estrogen. Yeah.
Yeah.
It's very
Interesting.
personalized.
Yeah,
Yeah.
absolutely, absolutely. It's risk versus benefit, right? And I mean, that is medicine.
Huh?
Yeah, and sometimes I feel like people get too stuck in the guidelines where someone's going to die from their mood disorder, like literally are going to get suicidal, and we won't just go into the gray zone a little bit and treat them with them being very well educated that there's a very, very small risk. And are you willing to take it?
Yeah.
How comfortable the practitioner is with that too as well. But yeah, when you're dealing with mental health, sometimes staying in the guidelines, so strictly hurts the patients more than it
Mhm.
helps them. The guidelines are so important. I almost always follow them. But I've also been in medicine 20 some years. Every single doctor out there will kind of ride the line a little bit if
Yeah.
it's for the best interest of their client and their client's agreeable, and because that's medicine.
And I tell people guidelines are just that. They're the lines that is in the highway road. They tell you, please don't go over there like you're out of the grass, but just stay in your
Mhm.
lanes. If you move
I love that.
lanes, that's okay. But there literally are just the white lines that is on the road. We follow them to tell us where to drive our car, but sometimes we get into other lanes. And that's okay.
Yeah. Yeah, absolutely. Absolutely. We sway a little bit and, no harm, no foul. So, yeah, I love that analogy.
So my client, she has a direct family history of breast cancer, and she was personally terrified to be put on HRT because her breast cancer family history has not skipped a generation. But she was so miserable in her perimenopausal symptoms that she just advocated for herself to her OBGYN to put her on something. So she didn't have blood work done, but she was having terrible hot flashes. So her OBGYN put her on an estradiol patch. And she started to feel somewhat better, but she kind of wanted to really see a hormone specialist because of her family history. But what her OBGYN did and is still doing is because she has such a strong family history of breast cancer, she's just monitoring her breasts more frequently. So every 6 months, she's getting either her mammogram or breast MRI. And I think that was so impactful. We talk about going against the guidelines because the guidelines would have said, do not give her HRT because she has such a family strong history. But this one woman was so miserable. She was like, I think I'd rather just have the breast cancer at this point because I cannot
Yeah.
function. Right. And so she's on very low doses of HRT. She's thriving and she's still just getting her every 6 month checks because she was going to get them anyway. She's like, I'm there every 6 months. So I might as well be on HRT and feel great because I know that if I'm going to have a breast cancer, well, it developed in the last 6 months. And I know that I can still do something about it. So I think that is just, she's like one of the perfect examples that I can give about, think about guidelines and stuff like that too. and advocating because she definitely advocated for herself for sure.
Yeah, I mean, we have to remember we need to listen to what our clients are telling us. I mean, our clients aren't downplaying their symptoms. It's hard for women to ask for help.
Yes.
So if they're, in your office and desperate and they're saying, I don't care, I have to have this, or else, it's not going to be pretty, we need to listen to them.
Yeah.
So unless there is a very clear cut, cannot do this, it's too dangerous, we need to listen to them. And then that goes into everything. There's, hormonal health, everything in medicine. I worked in a hospital for a long time in internal medicine, and we have clients that they're getting towards the end of their life, and it's like, here are the things that can prolong you 3 months, 6 months, or we have this if we don't do it. And so we're not prolonging their life. So one could look at that as you're not doing the patient justice, but the patient's like, I don't
Well,
want
I want
that.
that.
This is miserable. This is what I want. So, and mental health is, it's tough. There's not enough mental health professionals
Mhm.
out there to go around, and people are really suffering.
Yeah.
And so having these discussions and talking about hormones and your symptoms are real.
Yes.
They're definitely real, and we do have treatments for it.
Mhm.
So I love what you're doing. I absolutely love it.
Thank you. I love what you're doing as well because, I think we need more providers like us. And as I said before, I think, not only just for women, men, we talked about men's hormone health. That was never a thing, right? Like, you know, men got what they needed. And now I think it's time for women. And just like what you just said too, it's so hard for women to finally say something. By the time they have said something, they've been struggling with this for a while and they've tried everything that they know to try. And the most heartbreaking thing, which was also one of the things what made me do what I do now, is listening to women say, when I finally asked for help, I felt so dismissed, or they told me my labs were normal. And so they made me think it was all in my head. And I thought I was having, like a mental breakdown or a midlife crisis and all of these things. And it's because it's just not the right person listened.
Yeah, no, absolutely. I see that all the time in the ADHD world, and, even including myself, finally going and asking for help. And again, a very strong family history. I had classic, life of ADHD, working so hard to get to where I am, but struggle, 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 just your child for ADHD. It is to get to that point where you ask for help. You're like, you're embarrassed, you feel like a failure. You don't know what your doctor's going to think. Do they believe in ADHD? Are they going to trust your symptoms? Are they going to dismiss you?
Yeah.
Are they going to look at you like you're crazy? Are they going to look at you like you're drug seeking?
Yeah.
That is huge. Kids, they don't automatically have to do drug screens to get their ADHD medicines. Adults and most practices do. It is a necessary evil,
Yeah.
but at the same time is very disheartening. It's humiliating.
Yeah.
So by the time women do finally come around, and if they get that diagnosis and, going into perimenopause, what are the symptoms of perimenopause and what are the symptoms of ADHD?
ADHD.
Brain fog, poor working memory,
Yes.
feeling scattered, disconnected. Gosh, it's like, what's what?
What's what?
Yeah. So, specialists like you, specialists like me, we can go through, very thorough history, and it's not a snapshot in time. If your symptoms started yesterday, you don't have ADHD.
Right.
Sorry. Like you have symptoms that are very similar, but that's not the cause.
Yeah.
Going into, treatment, and we touched on this a little bit earlier. So the treatment for ADHD, when your stimulants start to not work as well because your estrogen levels are getting lower, you start perimenopause, and that's where I'm like, ding ding, hormones, like
Yeah.
I can't increase the stimulant dose. It's not going to work unless the hormones are balanced. So that time period, I send somebody to you and you do a fantastic job of balancing the hormones. Is there an age limit on that for, hormonal replacement therapy? What does that look like?
Yeah. So the guidelines, the most recent but still outdated guidelines will say that, we shouldn't really continue HRT past the age of 60. But there is a lot more research that is coming out. And it actually there was a consensus in July with the FDA challenging them to take off the black box warning for estrogen replacement therapy because they said we're actually doing women a disservice with this black box warning because estrogen, as I said earlier, it does so much more than just give you your menstrual cycle every single month, right? It is neuroprotective, it is cardiovascular protective, it protects your bones from osteopenia and osteoporosis. It protects your muscles. I mean, it does so many good things, right? So the latest research is saying that as long as a woman does not develop a true contraindication for her HRT, that she can remain on her hormone replacement therapy because of the cardiovascular protections, the brain protections, the bone protections, preventing this woman from getting chronic diseases in her later part of her life. So sometimes for my clients, what I'll do is for my women who are, a little bit on the more younger side and they're still kind of that perimenopausal journey, sometimes they may need a higher dose to really get them through. But after they've kind of gone through menopause and still sometimes they may still have some hot flashes, some of those other things. But the longer they get away from that menopause transition, the better those symptoms and stuff usually are getting. So we'll start to come back down on their doses, and putting them on a dose that's just more so physiologic, just to protect the brain, the heart, and the bones.
Yeah, there's at a point at a certain age where, estrogen receptors have an uptake, correct? And that's why they need less hormonal replacement is because it sucks that estrogen in and doesn't need that much.
Yeah. And I think too, even my clients who are on testosterone replacement therapy, if they were on it for the sake of their libido, they don't become just, abstinent from sex at the age of 60. If they're still married or if they're still dating, they still want to have that part of their lives. So why would I just cold turkey their testosterone replacement therapy? Because also that's protecting their muscle mass, which is also protecting bones, protecting the brains. And so I think we just have to realize what ultimately is this woman's goals, right? Women may say, okay, yeah, I got on put on HRT because my hot flashes were terrible. I'm over that now. I think I can come off. And so some of them will want to just come off because that's just what they want. But a lot of my clients too, I'll tell them, do you mind if we just come down on the lowest dose possible because I want to protect your brain, your bones as you get older? And they're like, yes, please. I don't want Alzheimer's. I don't want a heart attack. I don't want to fall and.
Yeah, absolutely. Those stimulants too, and working together in the perimenopause, menopause period, and the stimulants might work a little less because you need, more hormone replacement therapy.
Right.
And that's the driving factor. But after menopause, anecdotally, again, there's just not enough research, but you'll hear from, specialists after specialists. And there have been some studies, not big enough, but some studies that show that stimulants start to work better
Hmm.
at that point again,
Yeah.
because again, that estrogen uptake, right? And so you see, it's all about the estrogen. It's all about the estrogen. Before I forget, because, ADHD, you talked about men. And, as I was learning, more and more about ADHD and just trying to know everything I could, I'm like, okay, women, estrogen, huge impact. Men, testosterone. What do we got? Nothing. No, men, you don't get to be like us. So, obviously testosterone has its own issues as they're aging and everything, but is it affecting their dopamine? There is no research to point towards that at all. So this is mostly about women, but that's just a little fun fact. So, and talking about the hormonal replacement therapy too, before I forget to ask, do you like pills? Do you like the IUD as you're in perimenopause and you're trying to balance that before you get to your older women and estrogen patches? Or what does that look like for you
So that looks
with your
like the
treatment?
woman who is in front of me. So some of the women, they may want to have some form of birth control aspect. They don't want a perimenopausal baby. So for those women, I'm telling them, okay, great. If you want to, get a Mirena IUD. That's going to give you two things. One, it's going to give you the birth control that you desire. But two, it's also going to give you some of that endometrial protection for when you do get put on estrogen replacement therapy. Some of my clients, they don't want the pills because they don't want to remember the pills, so they want a patch. Some of my clients are like, give me the least amount of things to do as possible. So we combine their estradiol and their testosterone into one cream. It's like, I'll remember to take my pill, but I don't want, pills, patches, and all the things. So I'm always asking them, this is how we can do it. Which way is going to work best in your world where you're going to remember to do it?
Yeah. It's not the way I choose for you, it's the way that you're gonna follow.
Yeah. Oh, which way is gonna work best for you,
Yeah,
right? Because someone like,
yeah,
yeah, I like the idea of a
absolutely.
patch because I can put it on and forget it. I'm like, you can't forget it because you must replace your patch twice a week.
I would assume that women find a way to not forget that. Because as forgetful, at least with ADHDers, as forgetful as we are, we don't forget that medicine because it's a horrible day. And when we do, because it
Yeah,
happens, we're like, I'm finding a new strategy. It's going next to my toothbrush. It's because we're just not willing to go through a day without being able to
the
think
function.
clear. So,
Yeah.
yeah, I would think that that goes the same in your specialty too.
Yeah, for sure. And I was going to say too, going back to the research, I think because right now we've said, one of the common themes for our talk today was that there's not a lot of research with ADHD and menopause. But I think the millennial generation is going to bring the research because I think one, we're a lot more open about our menopause journey. But I think two, there's a lot of ADHD in these women who are in their 30s and and they're about to really go through menopause. And I think we're going to be able to see the impacts of the stimulants and the HRT and have some of that rich data. So I would also just say, if those clinical trials come up or there's some research studies that come up, ladies, if you have ADHD and you're going through perimenopause, like you are going to change the trajectory of what this journey may look like for your children, and generations behind you, because we're now getting to a place where those women who have ADHD are going through menopause, we're going to be able to capture so much more of that data.
I love that. I love that. The future is bright.
Yeah,
We just have to do
we just
it
got to
for
do it.
sure, for sure. And, having these discussions, that's the start. We're
Yeah.
getting there. It was so great talking to
This
you
was
today.
so good.
Yeah, absolutely. And, tell people how they can find you.
Yeah. So I'm on, I think, all social media channels just as my name. I kind of kept it simple, Mariah Prince Allen. I also have a personal website called mariahprinceallen.com. And then my practice is telehealthforher.com. The four is spelled out FOR.
Yeah. And you have a TED Talk
Yes, and I have a TED
too, which
Talk you
is
guys can
pretty
watch on
amazing.
YouTube. If you just YouTube, Google my name and put TEDx after, it'll bring up my TED Talk. So it's pretty good.
I love that. I love that. And I'm Tracy with ADHD Life Medical Associates, located in Fishers, Indiana. You can look me up at ADHDlifemedicalassociates.com or just make it easy, ADHD Life, Fishers, Indiana.